My name is Julia Christeller. I'm an intertrained clinician on staff at Psychotherapy and Spirituality Institute and also an alumni of One Spirit Interfaith Seminary. I want to welcome you here this morning. We are very excited about this talk. I have the privilege of introducing our speakers. I want to piggyback on one thing Jessica said about the Summer Institute also. If you are a pastoral professional or in training as a pastoral professional, we have had pastors come to this summer certificate program who have found it very, very useful in getting basic mental health education with a spiritual sensitivity. So we offer that to you as well, so take a look. It's my privilege this morning to introduce two wonderful speakers. Mary Ragan, who's our Executive Director of the Psychotherapy and Spirituality Institute and also has a clinical practice in Lower Manhattan at our Trinity Church Wall Street site. Mary has also been a consultant in addition to her practice to various leadership teams and also done consulting work that has taken her on-site in places like Bolivia and also serving in hospitals, and because of her interest in trauma work, has also done relief work after Hurricane Katrina and Rita. She is also a project director for a very interesting program. In addition to doing clinical work, we also have some programs out in the community, and Mary has founded a theater initiative called In Our Own Voice. Women veterans tell their stories. So it's something to watch for on our website. And I also want to say on a personal note, as you'll find, Mary is a consummate teacher and consummate listener. And we're very happy to have her as our leader. I also want to introduce Dr. Edmund Griffin. Is the Assistant Professor of Clinical Psychiatry in the Division of Neurobiology and Behavior, Department of Psychiatry at Columbia University. And he's also the attending psychiatrist at New York Presbyterian Hospital. Now that's a mouthful. What we know Eddie as is one of the newer members of our staff who has helped us bridge this world between spirituality, psychotherapy, and neuroscience, which you'll hear about this morning. We also know Eddie for his great humor, his good spirit, and his thoughtful questioning, which he will help you do this morning. So with no further ado, I turn it over to our speakers.
Thank you, Julia. Morning, everyone.
Good morning.
Eddie and I talked about how to approach this topic, which seems a bit vast. And we wanted to try and find a way to present it that would put some flesh and bones, real life issues that would be embodied in a case. So that I'm going to begin with a case presentation. This is a composite clinical case. Details have been altered to preserve the confidentiality of the people involved. So it is a fictionalized case, all of which is true. If you get what I mean. So I want to tell you about a woman who came into my office because she had lost her faith. And it wasn't the usual kind of loss of faith. It didn't involve church, synagogue, mosque, creed, or any talk of God. It was a loss of faith in humanity that happened as a result of domestic violence that was so severe that it ultimately led to the death of her only child and the suicide of her husband, who was the perpetrator. So this woman came into my office 17 years after the event. And she managed the trauma by working 2 jobs and never speaking of the horror to anyone. She just worked. And that worked. Sort of. She moved to another city. She found a different home. She got a new job. She essentially put herself like in a witness protection program, her own private Idaho, her own way of sealing herself off from the world and from other people, but most especially from her trauma. So she lived, and by the way, I know that this is an extreme example, and I use it not to exploit it, but because it is in the extremity of the trauma that the symptoms are so bold and glaring. For most of the people that I work with most of the time, it's not this. But this lives up, what we see in more nuanced and subtle ways with many of our clients. I wrote about this case years ago, and when I called this client I called her years after the treatment ended to ask her if I could write about it. And she paused for about a whole minute. And then she said to me, "Will other people be helped by this?" And I said, "Well, I hope so. That's the intent." She said, "Then yes." And we know that one of the measures of recovery from trauma, you say to yourself, how do you know when someone is sort of recovered from trauma? You know when they've been able to make some meaning of it. That's one of the signs of recovery from trauma. They've made meaning. And that's how I heard her question. Will anyone be helped by this? If so, yes. It's making meaning. So what she did was she lived a completely routinized life that consisted of work and work alone. Her schedule was entirely predictable. She was a reliable school nurse and coworker, and she dealt very well with the high school students that she interacted with. There was just one problem. She couldn't completely eliminate the automatic activation of emotion she felt upon seeing young mothers in the playground holding babies. That was too much. She could do the other stuff. She could be the school nurse. She could deal with, older children. But one mother holding a baby, she would say to me, "I can't tolerate the smell of a baby." The senses are critical in trauma work. It's what you see and hear and smell that activates that autonomic nervous system. That's your area. But that's really what captures it. So she couldn't be near a baby, but avoiding babies was a small price to pay for keeping the lid on what she was keeping the lid on, right? Small price. Just avoid the little ones. So, why then, you ask, did she come in 17 years later? Any thoughts? What would your hunch be about? Look, it's worked for 17 years. What's the problem?
Her mother died.
That's a great possibility. No. You know what happened? She was beginning to fall in love. Right. That problem. And she had relegated the trauma to the deep recesses of her psyche for a very long time, but she came because of love. And okay, so who saw the royal wedding? Who saw Bishop Curry get up?
Oh, yeah.
All right.
Yeah.
If you haven't seen Bishop Michael Curry give the homily at the royal wedding, I didn't know I was going to watch the royal wedding. I thought I pretty much but said no. And then he started preaching. He preached about love. So you have to see it if you want to see something really brilliant about love. Anyway, she came because of love. she was beginning to feel love for a man that she had become friends with, and the love was reciprocated. And it was the experience of the love that was the fuel for therapy. But you understand there would be problems, right? So she knew that she couldn't move forward with this relationship until she dealt with the trauma and the chronic PTSD. So first of all, cognitively, she had to deal with the assumptions that had been shattered as a result of her experience in this world. You may be familiar with Jenna Bullman, 1996, writing on shattered assumptions. And in that writing, the author writes about, in trauma, all of our assumptions are shattered. In particular, the client had to understand that the one assumption that was shattered was that she was invulnerable. We walk around thinking that. Why? I don't know. But we do walk around thinking that. I think we think that so we can get up in the morning. I mean, it's a good way to get up in the morning to, have enough of a shield to think that you're going to be invulnerable. Let's talk school shootings. Now, one of the most common responses that I hear with school shootings is, I never thought it would happen here. Right? We never thought it would happen here. But of course, why not? Why not? If it can happen there, it can happen here. But Ernest Becker's classic book, The Denial of Death, written many decades ago, is all about the fact that we live our lives with a shield in order to deny death. Why? So we can live. You do not want to live with death in your face, at every waking moment, because it's too much. It's too much of a strain on our defenses. People burn out when their defenses get too strained. And so she had to face the fact that the shattered assumption that she was invulnerable. Secondly, that the world was meaningful. She had an assumption that the world was meaningful. Not really. And thirdly, that other human beings were trustworthy. She believed that. And she no doubt believed that the most intimate relationship in her life was trustworthy. And that the greatest form of violence that one can think of would be perpetrated by the intimate partner, which of course is a very common event. We're always talking about the stranger in the street who's going to assault, rape, rob, or whatever, and it is the intimate partner where this is so often the case. So cognitively, she had to face all of that. Emotionally, she had to allow herself to grieve, which was a very frightening prospect. Can you imagine facing the prospect of grieving? Can you imagine allowing those feelings to surface after they've been deep sixed for a very long time? So she had a great fear of being engulfed by feelings, which, by the way, had been suppressed but not repressed. You know the distinction. Repression is an unconscious defense mechanism by which people really put out of their consciousness material that they don't want to know. And therefore, they don't know it. Suppression is conscious. Suppression means they put material out of their conscious mind, but they never forget it. They never don't know it. This is not a woman who came into therapy and said, oh, I just remembered about my child. Not at all. I doubt that a day went by that she didn't remember about her child. So the difference between repression and suppression. And biologically, she had to manage repeated episodes of significant dissociation, which became increasingly disruptive as the therapy progressed. She had a resurgence of nightmares that were variants of the trauma. She had one or two, what I would call brief psychotic episodes during the course of the therapy. She had an enhanced sense of numbing. And she had a forgetfulness that alarmed both friends, coworkers, and her therapist. Some of the things that she would forget. I mean, in the course of this treatment, I would think, what's happening? What's going on? And so the therapy dealt with all of these trauma symptoms, but it was love that was the healing agent. It was the love of this man who was outside of the therapy room. And I also think it was the love in the room. It wasn't simply outside of the room, it was in the room. Because this was a treatment that went for 7 years, often twice a week, including group. The group was a group for women who had experienced various forms of domestic violence. She was the teacher in the group, right? She was the teacher. It took her about 6 to 8 weeks into the group to say why she was there. So all the other people in the group are sort of like, like, and you're here, why? And the group had to sit with it, and they had to hold it until she was ready to say why she was there. I will tell you that at the end of that group, whenever it ended, a few years later, she didn't come into group until a few years into therapy, she was engaged to be married. And that group session, where that group celebrated that engagement, was an amazing moment. And you know what it's like when you're with people, this is the power of group. You're with people who've been through something that you've been through. And so the extent of the pain is so bad, the depth of the pain is so bad, but the experience of joy matches it. And so that's what happened. The group is the only place that could actually happen in a qualitatively different way than in one-to-one therapy. So it was love that was the healing agent. It was love that gave her the courage to leave the hermetically sealed world she had created to try something new, namely to try trusting again. She worked to create a narrative that could make some sense of the unspeakable and to restore enough of a sense of safety so that re-engagement with the world was possible, and specifically re-engagement with a man. Quite remarkable. So later on in today's seminar, I'm going to talk a bit more about the issue of spirituality. But just for this moment, I would like to ask you this question. If you were the therapist, can you imagine what some of your countertransference reactions might be in the course of this treatment? And let's hear from some of you folks. Yes, Kim.
Fear of triggering something like psychotic, going too fast, or
Yes,
right.
exactly. A lot of fear.
Mm-hmm.
I will own that.
Mm-hmm.
I will own that one. Yes.
I have a question. When she changed the narrative into an acceptable one, what was it? What was the acceptable narrative?
That's a beautiful question. Here's how I would put it. I think that the acceptable narrative was embracing the truth. So what did embracing the truth mean? it meant acknowledging to other people when she met them for the first time, oh, do you have any children? Yes, I did have a child. Instead of, no. That's taking a picture of the child and putting it up on her mantle in her apartment. Literally bringing that child back into her life. Having the courage to have the remains of that child, which were buried in a faraway state, removed and brought to where she lived and reburied with a religious ritual that she created. That was the new narrative. The new narrative was, yes, this is just as awful as you thought. This is a horror. This is unspeakable. All that's still true. But I'm going to reclaim. I'm going to reclaim my child, my life, my truth, and I am going to be able to talk about it.
Thank you.
Did
Yes.
she also make some kind of coherence out of her first partner's life and what happened to him and why he was what happened? Did she?
I think she had little interest in that. I just think that there was a lot of talk about that, but there was, I think, little interest in trying to understand what he'd been through. Michael?
As a therapist and as a parent, I probably likely would insert myself into what I imagined her trauma was. And I really feel it, and I would have to take the time to process it myself through the work together.
Yes, yes. Gary?
Yeah, that sort of picks up what I was thinking, that you asked about countertransference, and I was just thinking about all the things in my life that I would have suppressed, repressed, and not loved. And that love is such a powerful challenge.
Yes. Just for a word about my countertransference, I mean, it was sort of all over the place. I think it's maybe good I'm not a parent. I don't know. I think being a parent might really sink you in this one. But what I did feel is what Kim brought up about the fear. Because there were various points in the course of this therapy where she got much worse. And there was even a point where she said to me, maybe I should see someone else. And, we are always communicating, right? We are never not communicating. So I'm sure that in some way I was worried that she would get worse and not come back. And that this opening up would not be a good thing, but it was. More later, maybe. This out here.
Good morning, can you hear me?
Good morning.
Good. So I'm going to discuss this case from a perspective that allows us to start to try to see how we would look at this case from an integrated framework. You can go to the next slide. So, and I like that Mary described this as some challenges on the cognitive level, on the emotional level, and the biological level. And when we think about a case like this, often there's a difficulty, which is how do we conceptualize a problem such as this? Is this a spiritual problem? Is this psychological? Is this neurobiological? Frequently people go into one camp or the other. You could imagine how a neurobiologist or a psychopharmacologist might take a case like this and say, here's a medication that will treat your symptoms, and still be surprised that the person's hope, this patient's loss of faith in humanity remains, even when PTSD is treated. On the other end of the spectrum, one can imagine that encouraging love and connection would move things forward, but then be surprised that the intensity of the flashbacks still remain. The idea of psychology, spirituality, psychiatry, and neurobiology being three different camps is something that's very much ingrained in the way we think of things in our society. Largely, some of that stems from kind of the natural history of how these different fields emerged. Some people think of spirituality, psychology, and then neurobiology as part of an evolutionary process of how we understand things. So psychology, which is formerly the study of the soul, people think of as explaining things that were once upon a time described as spiritual in nature. And then neurobiology, which has really been emerging over the past 50 years, is often thought of as explaining the things that we see in psychology. What I'm going to try to do today is help us to understand that these are neither opposing constructs or even evolutionary constructs, but rather complementary things. Complementary constructs that we can see a case like this particular patient. What name would you use?
Why don't we use Mary?
Mary. The patient Mary. And we'll see how psychology, spirituality, and neurobiology overlay on each other in a way that we can understand this case. Next slide, please. So how do we get to this place of an integrative framework? Next slide. The first and foremost thing I'm going to be clear about is the distinction between having spiritually integrative care versus spiritually directive care. So when I say to a client or actually a colleague that I practice spiritually integrated psychotherapy, they look at me like this. And their first response is fear. Not suspicion. What do you mean, there's a God? No, theirs is fear, which is, are you praying with your patients? The idea that I'm directing is the first concern. Now I want to point out here that we're talking about spiritually integrated, which is different than directive care. The same could be said for understanding the brain. There is brain directive care, psychopharmacology, and doing things of the sort. But brain integrated is different. It doesn't mean that you're going in there and doing neurosurgery yourself. Right? You might, but that's not the case here. Our goal here is to move on the continuum and to be out of this category of spiritually avoidant care, where we don't recognize or acknowledge the spiritual dimension of our patients. Similarly, our goal, one of the goals I would have for us here, is to avoid this category of brain avoidant care, where we don't acknowledge that the brain is a machine and that it has certain principles by which it works. So we want to start moving ourselves in this direction towards being spiritually conscious and brain conscious, and ideally being able to integrate spirituality and an understanding of the machinery of the brain. So we're going to focus on this third category today and see if we can understand this case from that perspective. Next slide. So some folks get weirded out about thinking about neuroscience and this idea that we can have a language that everyone understands or that we could integrate things of that sort. So I'm going to actually start first by giving us a metaphor to use throughout this case. Something that's much more intuitive and that we all have a lot of experience with, which is understanding how the muscular system works. So the idea of movement and the muscular system, we all understand that people like surgeons, coaches, pediatric surgeons, mothers, fathers, that everyone involved in training a person to move, to stand, to run, to jump, everyone speaks a common language of how the body works. A lot of it is intuitive. And what we'll find today is that that same common language of understanding how a coach who's motivating this person to move would also be able to understand what a muscular orthopedic surgeon would understand as far as the muscles move. That same process of having an integrative understanding of exercise is the same way that we can begin to look at mental health or a case like Mary's. You can turn to the next slide. So let's take, for example, this is your patient and you are a physical therapist, but not a psychotherapist. If you're a physical therapist and this guy comes to your office with a trauma, and let's say he has a trauma where there's an injury in the Achilles tendon, it popped, trauma. And he comes to you as the physical therapist and says, I need help with my movement, I feel stuck. As a physical therapist, you need to understand things in an integrated way. On the one hand, you need to understand the muscular system. Understanding only the Achilles isn't going to help you much, right? You need to know what's going on with the Achilles, but also the supportive muscles around it. I don't know if you've ever been to a physical therapist who goes right in, is this where it hurts? Right? That's not going to help, right? Understanding multiple components of the muscular system is what helps the physical therapist get you towards movement. Similarly, a good physical therapist, or an astute one, is going to ask you questions about yourself. They want to know about your physical activities. They want to know about your goals and motivations. And there are two key reasons why they'll want to understand this. Number one is tools. Actually, number one is motivation. A person, if this is your patient and he is training for the Boston Marathon, is going to be a lot different than a person who rips their Achilles tendon and spends most of their time on the couch. Right? Your first goal of the first appointment is making sure that you get a second appointment. And a person who's motivated by something that's valuable to them, like the Boston Marathon, is much more likely to be engaged than a person who doesn't really need to move. So your first understanding of your client is, why does this matter to them? Where are they going with this? So understanding their goals and motivations is step number one. Step number two, the reason a physical therapist would want to understand about your context and the lifestyle you live is tools. Understanding the things that you do on a day-to-day basis allows the physical therapist to start to join you in your daily activities. Physical therapy happens for 1 hour, and they give you all this homework and say, do all these things in your life afterwards. The really good ones start to say, so you play basketball, or you have a son running around the house. Next time, why don't you start moving your leg this way? And they teach you to start to incorporate your movement into the life that you live. And we'll come back to that metaphor because, next slide, what I'll show you today is that akin to the muscular system is the brain. The brain is the machine that drives things in the same way that the muscular system drives movement. Mind is the thing that the brain does. A lot of folks think of it as a noun, but technically it's a verb. Emotion is a verb. Behavior, a verb. So these things are the correlate of movement. Similarly, when we think of things such as social, culture, and spiritual bases, this is the context. This is why we ask lots of questions. And unfortunately, that last component, spirituality, a lot of therapists and psychiatrists are taught don't go there. Yet, that's such a critical component of the patients, of many people's motivations and the thing that they hold sacred. That's going to move them. So to not ask about something like that is really going to miss an important way of drawing on a lot of strength of our clients. Next slide. So I'm going to go through a few principles of the muscular system to help us all understand how this works. So this is my son. So the first principle I want to teach you about the muscular system, we'll come back to the neuroscience, is multimodal processing. So my son kind of demonstrates this, and there was a little video, but I'll tell you what happened. So we were at a jungle gym, and right before he jumped on this trampoline, there was a 5-year-old who was just flying, and he's like in awe. So he runs over, and he glits on top of the trampoline, and he does this. And he goes, and he looks up to see if he's flying, and he's not flying. And he keeps trying it, one muscle, and he's not flying. The principle that he learned there is that, next slide, there is not a single jumping muscle. To jump, to get in the air, requires coordinated activity of multiple muscle groups. Similarly, in your brain, there is not a fear brain region. There is not a PTSD region. There's not a depression brain region. There's not a drug addiction brain region. For every movement, multiple muscle groups are required, and for every type of behavior, multiple regions of your brain are required. And importantly, and we might come back to this later, the last one, mastery of each of these muscle groups comes online at different stages during development. He can jump now. He's 2.5. Right? But these different brain regions and your ability to use them, they're not always there at different stages, and we'll come back to that. Second component of multimodal processing is recovery. Next slide. So it turned out that I did rip my Achilles tendon, and that picture you saw there was an idealized version of myself. So one of the components of multimodal processing is that injury in one region has a ripple effect to others. Because the muscle groups are all interconnected, if you rip your Achilles tendon, other regions start to atrophy. There's a ripple effect because of the interconnectedness. On the good side, because of the interconnectedness, stabilizing and overtraining one region helps the other to heal. And that's going to be one of the important components that we talk about in Mary's case, as far as the healing process. Because things are interconnected, on the one hand, the damage has ripple effects throughout our entire life. On the other hand, if there's something that can be strengthened, something that can be focused upon and built upon at a time, everything starts to follow afterwards. Next slide. So what does that mean as far as the brain? So in the same way that your muscular system has multiple components, your brain has multiple components. Your brain is a machine just like your muscular system that learns from its environment. It takes an environmental stimulus and an input, and then it processes it so that you develop a better and improved behavioral output. Now what's different though is that your brain locks in the memories. You've heard of muscle memory, right? Your brain does that 1,000 times over. It will record something and develop a smooth way of creating a behavior, but that gets locked in and it doesn't just go away. Next slide. So what are these layers that we speak of? So this is your brain, and this is a cross-section. And your brain can be thought of as in multiple layers, going from bottom to the top. And each layer of the brain, or each region, mediates important activities that all work in parallel at the same time to generate a behavior. So your brain stem right here, this region controls things such as your heart rate and your body temperature. Then when you get to the midbrain and limbic system, these regions control things such as anxiety, which is retreat behavior, or reward, which is I want it and I want it now behavior, appetite, sexual behavior, attachment, connection. And then as you get to the outer layers, the cortex or neocortex or prefrontal cortex, it's been called, you've heard several different versions of it. This region controls social behavior, abstract thought, connection, as well as top-down control. So each of these regions will work together to generate a behavior. So next slide. So in the case of Mary, when she has, say, a flashback or has an intense avoidance response when she sees or smells something that reminds her of children, what happens is that stimulus comes in and each region of her body will get activated. So in the middle regions, that's where the avoidance or fear response is. That fear response is also talking to her brainstem, which is going to drive up her heart rate, make her breathing more shallow, and she'll get a response that all works in concert. And meanwhile, the cortex, this observing region, this part that mediates awareness, is watching. Right? And that's an important component here, which is, and we don't know if lower animals have this, one of the key things and one of the key modes by which psychotherapy is going to work is that all these things can be happening and a person can become aware of it. There's awareness or mindfulness. Doesn't mean you can change it necessarily, but you can see it, and we'll come back to how that all works. So her response, her PTSD response, her biological response, is a concerted effort or concerted behavior of all these different processes. Next slide. So as I mentioned, if you look over on the slide on the right, there are rules to how these different layers work together. On the one hand, they work in parallel, but the neocortex, this outer region of your brain, is the executive. And as the executive, it means that you can be aware of the processes, and it means that you have a brake pad. What that means is you can have an impulse, an emotion, a desire, and at least temporarily, you can put the brake on. Which is to say, I feel this, I want this, but not now. right? We start learning that as we do potty training. It was one of our first exposures, and why Freud was so interested in anal retentive versus anal expulsive, which is you want to pee on the floor, you want to pee when you want to pee. But over time, the social pressures tell you that, hey, put the brakes on that. And how we learn to put the brakes on things early on becomes part of the process in which how we deal with intense emotions. This brake pad, or what's often referred to as top-down control, doesn't actually come online until around 21. So if people, obviously children, will be this emotional id, I want it now, and the emotions are very intense. That will continue on through 18, 20, where it might not have the same emotional scream as a 2-year-old, but the ability to inhibit, the ability to stop, just really doesn't start coming online to early adulthood. Next slide. Principle number 2 is plasticity. So plasticity is, oh sorry, that's not yellow, let's clarify. Plasticity is moldability. It says that the brain, even more than the muscles, can adapt, right? So if I want to work on my Achilles tendon, I could lift weights with this, and maybe one leg will get really big and strong, and your muscles can adapt by getting bigger, right? They hypertrophy. Your brain adapts by growing like leaves on a tree, right? Your brain, if it got hypertrophy, it would kind of crush inside your skull. So its way of adapting is to build more connections. And the brain is the most plastic or malleable or flexible and adaptable organ in your entire body. So 2 things that are important for plasticity. Number 1, during muscle development, just like we did here, there is increased capacity to heal. If he cuts himself, if he falls, he's going to heal faster than I will. So during the developmental region, the ability of the cells in the body to adapt and to change is like amazing. On the other hand, the risk for trauma is very high as well. So right, if he ripped his Achilles tendon, you would think 2 things. Oh, he's going to heal really fast. Yes, but if he doesn't heal the right way, if he doesn't heal with observation, that could get locked in a way that would be very different and much more traumatic than if it happened to me at over 20. Right? Number 2 is that few interventions, because of this plasticity, few invasive interventions are ever going to be successful without concurrent change in the environmental context. And this is where the psychotherapy component, spirituality component are so critical, is that I can go in and fix my Achilles tendon, but without a discussion of what kind of life do I live, what's important to me, what are you going to do now that we fixed your Achilles tendon? I might be back in the office in a week. In fact, that did kind of happen. Right? I didn't nobody talked to me about it, and you would think I know better as a doctor, but just the pace, I want places to go, things to do. And I'm on my little scooter, I'm pedaling fast, and boom. Yeah, context matters. Teaching new skills, teaching changes in behaviors is a critical component to any type of intervention. And I think I'm in a context where I don't need to explain that too much. One of the key components of neuroplasticity is that as you go from less complex brain regions, the brainstem is considered not complex in the sense that every mammal on the earth has that same neuronal wiring. As you increase in complexity, the plasticity or adaptability of the region goes up incredibly. So some components of that that are important for the work that we do. If you do psychotherapy, if you talk to a person, even the conversation we're having right now, very unlikely that anything is changing or adapting in your brainstem. And that's probably a good thing. You don't want random conversations to have permanent changes on the rate of your heartbeat or the rate of your lungs. Maybe acute or immediate, but it doesn't wire things differently. Similar is true for your limbic system. And this is important for our patient here, Mary. As an adult, your limbic system, your emotional system, does not change through kind of day-to-day activities. Or even an emotional conversation. Because it's not as plastic, only very big traumatic events can change it. Cocaine can change it. A very heavy stimulus is required to generate plasticity in this limbic system once we've passed age 21. Now, as a kid, yes, right? Every time, right, between 0 and 12, it really matters. This is why a lot of therapists really are curious. Hey, tell me about 0 through 12. Because that window is when the limbic system is developing. But once it's wired, really traumatic events can get in there and cause something. But as a therapist, as a pastor, as a friend, close friend or whatever, very unlikely that your work is changing the limbic system directly. What it does change is the neocortex. The neocortex, because it has top-down control, is the thing that allows things to adapt over time. So when we're talking, this part of your brain region, prefrontal cortex, is adapting in real time, right? I'm not the same person right now in my brain that I was just 15 minutes ago. Things are adapting very fast in the cortical regions, but not in the limbic system. Next slide. So what does that mean when we think about Mary's case? Prefrontal cortex, or I call it neocortex, the observing self and spirituality. The prefrontal cortex is the region of the brain that causes this top-down control and can start to silence and quiet some of this reactivity that we see in our patient. The counterintuitive thing is, how do we go about strengthening that top-down control so that she can live her life? Intuitively, we would think, oh, think hard and block those terrible thoughts. Right? That's the intuitive thing. The more she presses the brake pad, the stronger the brake pad should get, right? But in the same way that we know our muscular system doesn't work that way. That if I want to fix my Achilles, pulling on the Achilles isn't the way that it's going to get better. In fact, it turns out that in order to strengthen that brake pad in a more permanent way, it's actually better to release it. Not to avoid it, not to suppress or repress it, but acceptance. The thing that we push against is the thing that gets stronger. And it's one of those ironic truths about the way our nervous system works. If you have pain in your left knee and you're thinking about it right now at this moment, you feel that pain, don't you? When we shift our awareness to something, it actually gets stronger and reinforced. If we say that we've repressed something and we're blocking it and we kind of grin and bear it, in the addiction field we call it white knuckling, right? It's still there. You're still activating it, even if you're grinning and bearing it. So the idea of pressing on the brake pad to block these emotional responses, sure, it will get you through the day, but it's actually strengthening that limbic system response. And this is where things like mindfulness, other forms of spirituality, we think of mindfulness in the sense that it's manualized, meaning it's something where you can do this, this, and this, therefore it's more studied or easier to study in clinical trials. Mindfulness, the idea of acceptance of an emotional response without actively engaging and struggling with it, allows for the neocortex to start putting down those inhibitory circuits. Similarly, and we spoke about this at the very beginning of the case, where spirituality comes in, is not just as a tool, meaning a way for her to accept emotions or reframe, but also as a magnet, a purpose, a reason. The neocortex, once it finds something that it does focus on, it is motivated, or it starts to lay down the circuits to inhibit things that are preventing that from happening. So using this framework, brainstem, limbic system, and neocortex as the three regions of the brain that are working in concert to generate both an internal experience as well as our motivated behavior, is one framework where we can start to think about how biology, the psychology, and spirituality all start to take place, both as far as how the machine will work, the general principles of not actively trying to block an emotion, but moving forward to something that's valuable, is a way that we can start to construct this case.
I can understand how that works in the suppression piece. Does it work the same way in the repression?
And repression. So, remind me, Mary, again, which one is which?
Well, repression is the unconscious defense mechanism
So
in which I,
repression.
move material outside of consciousness.
So repression, so your brain is a machine in the sense that it will make decisions for you without your knowledge. A lot of your emotional responses, thoughts, feelings, triggers, there are a lot of them happening right now at this moment that you're not aware that you're repressing. Some things will get offered to your brain that never even reach consciousness, and you know what? That's often a good thing, right? If we had to look and be aware of the many different types of emotions and impulses that we have on a daily basis, we would never get out of the room, right? Because we've experienced so many different things, either directly or vicariously, that your brain has a lot on its going on there. Right, so there are a lot of impulses, thoughts, emotions that are happening every day, and they get shuffled out and kicked down often, and that's how we're able to function. Right, so on the one hand, it's a healthy thing. The idea of repression, meaning your brain, it was such an intense emotion that your brain made an executive decision not to deal with it, is tricky because if the emotion is very strong, it can still have a hand on the wheel. And that's where it becomes a little bit of a tricky thing. And that's where you have a person not being aware of their emotional response, but it's still happening. And this is one of the difficulties in psychotherapy, is when the person is doing or behaving in a way, but their ability to look at it and see it is not there. And this is where you get projective identification. What do you mean? What are you talking about? Or passive-aggressive behavior is where the awareness, the brain is holding so strong to prevent that from awareness that it's very difficult. So that's how we're kind of working in concert. And why does the brain make an executive decision without your awareness for some people and not others? Often because it's learned to do that between 0 and 12, because it had to, right? This is the injury of a kid during that early process. If it gets locked in, that's the way it's going to roll. More questions, please, about this. We have another 5 minutes.
I just wondered how it fits in with like EMDR, with using bilateral stimulation, or in internal family systems where you use the brain analytical and then you go into imaging more, and just how the using the neocortex but really breaking it down into left and right hemispheres.
So when I mentioned that these brain regions are not plastic, I'm cheating a little bit in the sense that 2 techniques that come to mind that have been shown to trick it, the limbic system. I would call it more of a, it's not learned behavior, but it is learned. Basically, it's using learning and memory to rewire this region. So number 1 is breath. I'm just going to mention 2 in concert. So breath, the idea of changing the rate of your breathing. There's a nerve that goes from your lungs to your limbic system. And it's a feedback, right? So if I get scared, I go into fight or flight. Cortisol happens, my muscles get tense, all the blood starts flowing, and my brain's ready for something. If I force my breathing into a slow rate, it sends a signal through the vagus nerve, actually directly to your limbic system, and says, hey, nothing's going on here. And even though there still might be a lot going on here, it's a way in which the body can actually talk back to the brain. Does it wire it differently? That we don't know. We do know that in the moment, it can send a signal back to the limbic system and get it out of fight or flight. Whether or not doing that over time and time keeps it out of fight or flight has not been proven in studies yet, but that's one. Second one, as far as EMDR, it's taking the limbic system and the cues that it's attached to certain triggers and rewiring it in a way that it's connecting it to a different cue. So whether or not it's eye movements, tapping, or any number of things, if the brain starts to associate whatever cue that it had with the thing you're doing as opposed to the trigger, it's another way of moving the neurons so that they're reacting differently under different contexts. Desensitization, similar, right? So there's desensitization ways. It's in that category of kind of rewiring through more therapeutic specific techniques.
And if an event was that traumatic that it was repressed in the brain, would it have the ability to make a change in the limbic system?
If an event happened to the extent that it was suppressed, repressed, meaning the person's not aware
Correct.
of what had happened or in some kind of severe
But if it
denial,
was that traumatic, would it have the ability to make a change in the limbic system?
would the event or would the therapist help? Does it change the limbic
Yeah,
system?
correct.
Oh yeah. Oh, these things change. So a high stimulus traumatic event creates a change in your brain. The idea of it being repressed means that you're not actively aware that the limbic system has learned from that, but it learns because that's a survival part of the machinery. So if a big event happens that is connected to your survival, your brain's going to record it. So rarely do you see a person go through a traumatic event and then just kind of walk into it again without having a very intense response. Quite the opposite. They might have a traumatic event, repress it, and say it didn't really matter, and then find themselves under random cues. Why do I feel this way? Why is this happening? Why is my heart all of a sudden racing? And so yeah, it changes no matter what, the brain, because it's such a high stimulus.
Hypervigilance.
Hypervigilance, yes.
I have a hospital patient as a chaplain who has dementia, lost her husband a few years ago in a traumatic way to a very rare parasitic disease. And she's traumatized like every 5 minutes by his death. I can redirect her to what made them get together, stories about their past. So the neurocortex is compromised. What, as I'm trying to explore other ways to make meaning. Any insight into that 80-something?
With some dementia. That question comes up a lot with stroke patients. So if you have a stroke, you can't move your right arm. Your brain will compensate and start sending new neurons over to start controlling that region. And the difficulty being, though, that people tend to have strokes not when they're in their 20s or in their teens. They have it later in life. So there's been studies that show that folks nuns who've done crossword puzzles, I think was with the study, that people who exercise their neocortex have more plasticity later in life. So their recovery of movement with things post-stroke is enhanced. The question then would be, is there something that is exercised in her lifespan, that was meaningful to her, be it, art, indoor, or tennis, music. There are certain things that remain locked in the brain in long-term memory, even with dementia, and it's amazing. Music is one of them. Smell is one of them. Now I'm going off of more experience than studies, but those are the two that come to mind. So and then things that they've done that have been important to them and kind of exercised over and over. Things like music and smell are just purely biological. Your brain just kind of locks those in, and those always remain. Other things that the person has done throughout their lifespan would be more, and then kind of connected with people.
Forgive me, I'm not physiologically educated about all the brain thing, but I'm missing something. If the brain is recording these traumas, your previous statement that we don't know whether breathing and mindfulness affects the brain or can change the brain, why don't we know that?
Gotcha. So there's, so going back to our muscle approach, so I'm moving my arm right now, right? So I'm activating my muscles. Is that going to make my muscle grow? Not necessarily. It's not challenging it. It's not pushing it to any type of limit. It's just using what's already there. So there's using a neuronal circuit, meaning making use of it in the moment, which is I'm moving right now. And then there's learning, right? So for learning to happen, just like muscular growth to happen, there has to be something novel, something different. So when the exercise trainer says, vary your workout a little bit, or change your reps to kind of make them intermittent, the reason for that is that for muscle memory to happen, the system has to be pushed. Otherwise, you're using it. So when we talk of momentary relaxation techniques, that process isn't necessarily pushing the system enough to kind of lock it in as a long-term change. So that makes sense?
That's it right there, the terminology, momentary versus sustained.
Yes, momentary versus sustained.
That's where I was.
To go from momentary to sustained, just like the muscular system, the brain system needs either novelty or high value. So things that are either big and juicy or important, let's say, because they can be either good or really bad, or novel, are the things that induce sustained change. Thanks for asking that question.
If you would, I'd like to take the next 5 to 7 minutes in pairs or 3, and I'd like you to share with one another, in your experience growing up, what role, if any, did spirituality play? If any. 5 minutes. In pairs or 3 people. Let me hear a sampling of the role of spirituality, if any, in your life growing up. Anybody at all? Yes?
We seem to have a commonality in my spirituality
Spirituality slash
religious upbringing. I became very hypercritical and critical about spirituality because we went to church religiously, but the things that Jesus and God were conveying to us during those 2 or 3 hours at church were not lived during the rest of the week. So we discovered that intergenerational kind of commonality.
Interesting.
Yeah.
Was the problem with Jesus or the preacher? Yes, Ellie.
Well, we were talking about sort of Catholic upbringing, and although we're no longer practicing Catholic, that idea that the world was sacred, there was a loving God who was eternally present in all things, and that the holy was all around us is something that we took away even if we're not part of the Catholic Church anymore.
That's interesting. So there's something there that is in you.
That's cellular. That's really
Cellular, DNA. Got it. Yes.
Yes, I also grew up Catholic, Latin Catholic, Latino Catholic, which is a very much more spiritually infused form. However, I grew up in a very unsafe home with violence, and so what actually I cling to that was spiritually based was going outside, and I was telling David, and just smelling things in the air, and anytime I would smell a particular cinnamony smell, I felt like someone was saying, all will be well. So it wasn't beliefs that helped, specific Catholic beliefs. I started to reject them early because, I saw too much evidence of bad things.
Yeah.
So it was things that made me feel safer or things that felt sublime, like a scent, like music, or one thing that me and my sister did when we were about 6 or 7, I don't know how we knew to go there. There was a little church on the way to school where the priest would give a blessing in the morning to the students. I don't know what made me go there or how I knew about it, but it felt like someone cared about me. So it wasn't the religious connotation as much as someone cares, someone loves, somehow, you know, there are places of safety.
It's a beautiful description. Really beautiful.
From my own opinion, I'm from Northern Ireland. I'm Catholic from Northern Ireland. And again, it's part of your identity is who you are. Like we have maybe like, probably, you know, the city I come from is 150, 200,000 people. There are probably 2 Muslim families in the whole city.
Right.
And your school uniform that says you're a Catholic school, that is, you have an area you're safe in, that's where you're safe to be a Catholic. There's certain areas in the city where you would not go in a Catholic uniform because that's a Protestant area. And the troubles are, you know, there's still problems in the teenagers there today, fighting amongst each other because at
Still
15,
today.
yeah, well at 15 you don't know what to do with your emotions and you're the other side and this is my side.
Yes.
You know, so it gives you a sense of community in one way but also as a division in another way.
Yes.
So it's that kind of double-edged sword, I guess.
Well, golly, if you're from Northern Ireland, you have a very profound experience of the role of religion
Yes, definitely.
and how people choose their tribe.
That's how Kim and I were mentioning that until I went to college in England and stepped out of the them and us, even though we're both Christians and believe about 3 different things, you know, like there are 2 or 3 things that really separate us.
Yeah.
Until you actually see, I went to Manchester, which is predominantly like Anglo-Saxon, Protestant, lots of Muslim, Hindu, and until I seen all these other things, I was like, how can this street full of so many different people go out and do their own thing? And then where I live, there's literally peace walls which are 40 foot high with broken glass and barbed wire on each side.
Is there a paradox here about the peace wall?
Yes, most definitely. So it's interesting to then be taken outside that situation and see. And I just most recently went to Vietnam, and you know there's lots of the Hindu aspect and the Muslim and the Buddhism aspect and all these lovely, you know, Confucianism and everything is all together in this area, and there's no trauma. Why are they not fighting each other? You know, like I know they were at one point, but you know, like it's 2018 in Northern Ireland, that's still happening. You know, like it's just so insular.
Yes.
So, and it is a big part of who you are growing up until then you're one of the lucky ones that decides to move away to go to college. And all of a sudden you see, oh wow, wait, oh wow, there are good religions.
You know, an interesting thing too,
Yeah.
I mean, I grew up in Los Angeles, quite different than Northern Ireland, but in this, we had a very similar experience in that my fundamentalist grandmother had a strong influence on me, taught me from a very early age that only Christians go to heaven. Anybody else, Jews, Muslims, whatever, are going to hell. Unless they're saved, you know, and that was a part of my understanding until I went to college, and everything changed when I went to college. But it was, even in Los Angeles, you could
That insular world
Yeah.
where we're saved, they're not, and we know that we live in a world now where the other is a very profound and prominent theme about the mother.
Yeah.
They must be kept from us because they are the other. And you know, it's very interesting to probe that more about what does it mean to be the other. And by the way, who is the other? And how did we get to be, you know, the default, you know, mainline primary choice? It's very, very significant. Other folks?
That
Yes.
can be explained through history, actually, why we are the default.
Yes, I'm sure it can.
I could explain that.
Do you want to do 3 sentences now? Okay. I know you're right. Paul.
Oh, we were also talking about our Catholic upbringings.
We got some Catholics here.
Yeah.
Never mind. You now.
Yeah.
We got some Catholics
Yeah.
here.
Some ex, some recovering, some
Yeah.
still sticking it out.
Yeah.
And actually, for me, I think one of the reasons I do stick it out, there are 2 main things. One was there were a lot of priests and nuns in my family. Mainly my mother's siblings, and though we were very devout Irish Catholic, there was no mystery or sort of clericalism about that. And that's Uncle Ed and that's Aunt Marie and that's they were human, and it was very much just they have made choices to devote their lives in a certain way. It wasn't magical. It wasn't right.
Yeah.
They got respect for their seniority in the family, not for their religious position. So that was very helpful. And then the other was very simple thing. My mother used to tell this story all the time. There were 12 kids in our family, so we would come as a brood and take up,
Catholic.
Very Catholic, yes, and no TV. But one of us was running around being disruptive or whatever, and my mother hated it, and my father said, "It's his father's house; he can play here." And that was something that we were all taught and told. And that's a really core thing. I won't be thrown out of my own house. As a gay person, you're not throwing me out of this house. If I choose for some reason to leave, that'll be on my terms. But so those kinds of things made for
Thank you. I want to just move on for a moment about having heard your commentary, because how many people in this room are in some form of helping profession? There you go. Okay, that's why I brought this up, is because we come as the helper into whatever setting that we're in with a template about spirituality and religion and God and such. We come with a template born of our early experience and no doubt modified and changed and so on as we grow into adults. But we come with stuff, and we bring that to the pastoral, political, hospital situation, whatever that helping situation is. We bring that template with us. And religion can heal and religion can harm, and it does both. And so it's very, very important to be able to, sort your way through. First of all, what has the healing been for me in terms of religion and spirituality, and what has the harm been? And have I done the kind of work that I might need to do about that healing and harm in order not to be projecting onto the person that I am helping my own unprocessed, unresolved issues regarding religion and spirituality. It's a very, very important topic. The psychotherapy that I described with my client, in my opinion, was infused with spirituality, with little mention of God. The therapy was about restoring wholeness and making meaning of the unspeakable, figuring out how to choose to live again, because life had been on pause in a certain kind of way. It was about creating rituals, some of them religious, to reclaim the child she had lost so many years before. I had an interesting experience at this point in the therapy when she had the remains of the child brought back to be buried in a cemetery very near where she lived, which was here in New York. And I had been such a part of this story for so many years. I had a deep desire to be there at the burial of these remains. And yet, what I came to understand eventually, number one, she didn't invite me. And number two, she needed to come back to tell the story. She didn't need me to be there. She needed me to be in my office, where she would come back and she would recount. here's what happened. I recommend to you, if you haven't read him, an Irish poet and philosopher named John O'Donoghue. You know him. Wonderful book, Anamkara, Soul Friend. Another wonderful book of blessings, and Bless the Space Between Us. Died too soon at 52 years of age in his sleep. But I want to share with you his definition. Imagine a definition of God. It sounds like a contradiction in terms. But his definition of God is beauty, which is what I think of when you describe being outside. That God is beauty, and every encounter with beauty is an encounter with God. And his definition of spirituality is homecoming. So any time you have any kind of experience of homecoming, and we have them, right? We have them in little tiny ways during the day and the week, and then sometimes we have them in big ways. That's a spiritual experience. And so that's a kind of description that resonates with me, and I wanted to share it with you, and share with you something that O'Donoghue says about spirituality and about homecoming. He says, when we cross a new threshold, if we cross worthily, what we do is we heal the patterns of repetition that were in us and that had us caught somewhere. And in our crossing, we cross onto new ground where we don't just repeat what we've been through in the last place. Beauty, in that sense, is about emerging into a newer fullness, a greater sense of grace and elegance, a stronger and deeper sense of depth, and also a kind of homecoming for the enriched memory of your unfolding life. So for me, the experience of the therapy that I described to you and the felt sense of the sacred was almost one. It was like that was it. That was the deal. You didn't have to go outside of that. You didn't have to go further than that. It was happening in the room, in the relationship. Spirituality does not always help. Religion does not always help. So just a few thoughts on that. The DSM-5, as you know, for those of you who are clinical, deals with something called spiritual and religious problems. And so, we'll go to the next one. This is about differential diagnosis regarding religious, spiritual, and transpersonal experiences. So, one of the first things that the clinician might need to do is to accept the reality of these experiences. So if you have a default position of, well, this is crazy, that is not helpful. You need to understand the client's religious history and background as well as your own, and what you're carrying with you from your own. To realize that psychopathology is not determined solely by the content of the experience. This is pretty important because this has to do with culture. This has to do with various traditions. You know, what looks crazy to me might be absolutely normal in another culture, and it's called cultural competence. And you need to be able to assess adaptive functioning before the experiences so that you know who is this person before the experience. Here are some of the ways that you assess the orientation of the client in terms of spirituality. Do the current behaviors exceed religious injunctions? In other words, are you holier than thou? Do you need, you know, the rule is this and you need to do this? Does the client overemphasize certain practices and neglect others? For example, family life, one's spouse or partner. Do beliefs and practices promote wholeness, relatedness, and full humanness? And then I also refer you to the work of Groff and Groff, Stanislaus and Christina, on spiritual emergency and spiritual emergence. It's very, very interesting because what they're talking about is a spiritual emergency is when a person is overwhelmed by the unconscious material that floods them. And they are in an emergency state because they can't process everything that just came up. And that's called a spiritual emergency. But spiritual emergence is a benign unfolding of unconscious material. It's not full of terror or distress, but it's much more benign, and it offers a person an opportunity to reflect on what is this that is coming up in me. You need to be able to determine the nature of the spiritual or religious problem. Is there a concurrent mental disorder? This is another kind of problem is that, just because I have a mental disorder does not mean that I haven't also had a spiritual experience, right? It's so easy to take the mental illness or the mental disorder and assume that this description of spiritual experience simply is not possible. Is the spiritual problem not attributable to a mental disorder? You may have noticed that people who have certain kinds of mental illnesses have an overabundance of religious imagery and thoughts. And religion plays a big part in their mental illness. Recognize that psychopathology is characterized by greater intensity, terror, and decompensation than genuine religious experience. So if a person is in a process of decompensation, that experience that they're calling spiritual is not healthy or helpful, and is more likely rooted in some form of pathology. Some markers of religious psychopathology. Narcissistic displays of being religious. Sometimes you can get this on the morning shows. The mega preacher. Religion as reward. If I do this, then I get that. And it's a kind of transactional thing. Scrupulosity, otherwise known as OCD. Intense focus on avoiding sin or error. There is great, great suffering for people who deal with scrupulosity. Great suffering with OCD. And very often religious rituals and OCD get confused and combined. Relinquishing responsibility, neglecting responsibility for manageable things. In other words, I'm really living on another plane, and I'd like to help you out, but I can't, because I'm on this other plane, which is very spiritual. That's a question mark. Other signs of psychopathology: ecstatic frenzy, emotional expression that contains religious content or occurs in religious context that may signal impending decompensation. This gets tricky. This gets tricky when you have people speaking in tongues, because people speak in tongues. And so...
I have a great podcast about that if anyone's interested.
Do you? So how do we find it?
So it's a podcast called The Liturgists, and it's a little bro-ish, so white male heavy, but these are mostly young men and women who come out of the evangelical tradition, who've had experiences speaking in tongues, and it comes from more kind of progressive understanding of faith. And one is a scientist, and so they taught. It's an hour-and-a-half podcast. It is really, really phenomenal. They address it with gentleness and also with a critical eye. And the liturgists.
The liturgists.
Yeah.
That's great.
Yeah.
Take a look.
Yeah.
Indiscriminate enthusiasm, pushing religion on people who do not welcome it. Do not do that.
Yeah.
It is not a good idea. hurtful love based on setting unrealistic expectations for a child on strict Bible interpretations. I've had a number of clients, you know, can we leave that door open? That'd be great. It's heating up in here. I have had a number of clients who've come out of this kind of strict, fundamentalist, homeschooled, religious teaching background who have some hard time, you know, working through that. And the notion that the Bible is a moment-to-moment guide to living, just like a horoscope, not really. You can find anything in the Bible that you want to support any position that you can. And so it takes a more sophisticated understanding of Scripture. So let's hear from you. What kind of and Eddie, do you have any thoughts you want to share here? Or?
Can you go back a little?
Yeah.
Just to put it back, I'll make sure that we're keeping, bring some brain biology back into this. As far as the types of problems or the type of therapy, this is the closing, that's the part that I want to connect with again. The way it closed. And the type of spiritually integrated work that is helpful. The idea of the sacred, I just want to touch back on that again. People will be involved in groups, religious affiliations for lots of different reasons, right? There are many things that can draw a person to a room of people. It can be affiliation, a feeling of unity, a feeling of belonging to something. There are many layers to peel back when one thinks about what drives a person to be religious or spiritual. I really appreciated how you highlighted the importance of sacred as or the hunger for it as a driving force. And then when you look through that list of pathologies of spirituality, you start to see other types of things that do motivate a person for different reasons. And I think to be careful not to over-pathologize the important how a person might view get involved in a more legalistic approach to things. There might be a benefit for that person at that time. The question comes back to what is helping them in this moment in the therapy, and kind of our role of helping them to discover that idea of the sacred as kind of a drawing force that would pull them along. Because again, the idea of making change in the brain, high value is the critical component here. The things that we value, if they're consistent with these parts of the universe, are going to help drive this behavioral change.
Why don't we take just one more question, and then we would like to pass out evaluations, because one of the things we want to do here at PSI is provide more programming and to do it in a way that's better and better. So we really would love your feedback. Is there anybody who wants to? Yes, Kim.
I mean, it's not really a question, but it evoked something to be thinking about this client that I'm currently working with. When she originally came to see me, she told me that the her spiritual facilities were opening up, that she was becoming like a medium to help people sort of cross over. But as I've worked with her, what's been interesting is that she's not hearing voices, and she doesn't really fit any DSM criteria. She's very cognizant and aware that this may sound crazy, however, this is what I'm experiencing. And what's been interesting about it, and this may be somewhat deeply psychological, is that it's really helped her individuate. That in the process of her psychic abilities opening up, she has made these huge changes, positive changes in her life. Moved out, she's in her 30s, moved out from her parents' house, got training in Reiki, started looking to start her own business, changed her friend groups of much more nurturing, supportive people. And she feels like she's being her true self, but she's being overwhelmed sometimes by the amount of traffic that she's getting from spirits that want to cross over. So I've been like trying, you know, and it's very real for her, and it might be actually happening, I don't know.
And then I would want to slow it down. You know, whatever's
Right.
happening in the therapy to try to slow it down a bit so the circuits are not overloaded.
Right, I've been more looking at like how's it affecting her, rather than pathologizing the opening up.
Right.
Like what's it like for her feeling overwhelmed by all of these?
Yeah. So we want to just thank you all for coming and ask you to fill out the evaluation. Can we get those?
Yeah, and if you're getting CECs, you have to fill them.
Yes, if you are getting
We want you to
CECs,
fill out.
once you have filled out the application, please come see me and I'll give you your certificate.
But we'd like an evaluation if we could. Thank you very much, folks.
Thank you.
Thank you.